Ladies and gentlemen, welcome to Clinical Journal Club for December 5, 2018. And the picture in the New England Journal concerns a 58-year-old man who presents with a 2-year history of hoarseness and this peculiar lump in his neck. The lump seems to be non-tender. It's compressible. We aren't told that it's pulsatile, but at least it isn't hard and fixed. We're offered saccular cyst, laryngocele, thyroglossal cyst, scrofula, and lymphadenopathy. Now, the structure is not in the midline, so this is not a thyroglossal cyst. The structure isn't ulcerating, and scrofula usually concerns ulcerative lymph nodes from tuberculosis, so that's also unlikely. Lymphadenopathy is always a possibility. I'd expect the lymph nodes to be immediately anterior to the sternocleidomastoid muscle, which is not the case here. The lesion certainly looks like it could be saccular, and since the patient has hoarseness, we would have to pick laryngocele, or that would be my choice. If that were the case, it might even be filled with air. Nevertheless, this is a saccular lesion, since it's a dilatation of the laryngeal saccule, which is a blind pouch between the true and false vocal cords. That's the best answer that's offered us. Now, there are case reports of this, and I assume that this is a lesion that's seen internally during laryngoscopy in this case report, but actually, the lesions should actually emanate here immediately above the vocal cords, and this cystic saccular lesion might actually be filled with air and almost as if it were a blister. And here's an operative view where one of these lesions is excised. Thyroglossal cysts ought to be in the midline, as this ultrasound shows here. They're a remnant coming about through thyroid gland development. This is an example of scrofula, which classically involves tuberculosis, and commonly these lesions ulcerate, but this involves tuberculous lymph nodes, which ought to be immediately adjacent to the sternocleidomastoid muscle. Oh, God. We can look to see where relevant lymph nodes would lie. Here are anterior to the sternocleidomastoid muscle, or in a line adjacent to the lower jaw, or perhaps behind the ear. This lesion would be compatible actually with an enlarged submandibular lymph node, but with the history of hoarseness and the physical findings, the diagnosis that we made would be more likely. The first topic in the New England Journal concerns the proprotein convertase subtilissin kexin type 9. Thank God that's abbreviated as PCSK9. And PCSK9 can be a circulating protein, but it functions as an adapter protein for the LDL receptor. And when PCSK9 binds to the LDL receptor is internalized inside liver cells mostly, and is degraded, and is then no longer available to accept cholesterol. PCSK9 was discovered in Mendelian diseases. People that had overactivity of PCSK9 or produced it in untoward amounts, in essence, had a familial hyperlipidemia type syndrome. People that had a deficiency in PCSK9 had very low LDL values and appeared to be protected from cardiovascular disease. For this reason, strategies have been developed against PCSK9, in the hope that we could reduce circulating LDL levels even further than can be accomplished with statins. So these drugs are commercially available. They're antibodies against PCSK9 to my knowledge. And preliminary data also published in this journal suggests that they're highly efficacious in lowering LDL cholesterol levels below 50 milligrams per deciliter, even as low as 20 milligrams per deciliter, as we would find in the average mouse. There are also genetic strategies to lower the production of PCSK9, but what's concerned here is an antibody against PCSK9, and the object of this study is to show that lowering LDL cholesterol to very low levels decreases hard endpoints such as coronary heart disease, and the primary endpoint in this study was a composite of death from coronary heart disease, non-fatal myocardial infarction, fatal or non-fatal ischemic stroke, or unstable angina requiring hospitalization and coronary intervention. There are almost over 9,000 patients in each group here, so large numbers of patients were recruited that were already treated with statins with a goal of lowering their LDL levels to 70 milligrams per deciliter or less. These patients were randomized to get either placebo injections or injections of this antibody against PCSK9, which had to be injected at 4-week intervals, to my knowledge. The control patients received placebo. Now, what we can see here is the patients that received placebo already had LDL cholesterol levels of around 90, which is pretty reasonable control. The people that got the antibody in the intention to treat analysis, their LDL cholesterol values dropped to less than 45 milligrams per deciliter. Thereafter, they gradually increased because some patients were lost to follow-up or didn't show up for their injections or whatever have you. Since this analysis is intention to treat, the values are a little bit higher as they were in reality. Here in the hashed lines are the patients that actually got drug, and they were reduced to 53 milligrams per deciliter on average. And what we see here is that indeed the primary endpoint was met, statistically highly significant difference. That means that patients were protected from this composite endpoint of coronary heart disease, non-fatal myocardial infarction, stroke, unstable angina, etc. And even any coronary heart disease event was reduced. Major coronary events were reduced. Cardiovascular events in toto were reduced, and the composite endpoint we've already discussed. That is favorable. However, if we look to see what really happened, first of all, the number of events in these patients that already were treated with other drugs to lower their LDL cholesterols to 90 milligrams per deciliter, they didn't have many events. And indeed, the patients that got the antibody had less events, but the difference is about 1%. That means that the number needed to treat is about 49 patients that have to be treated for 4 years to avoid one composite endpoint. Highly statistically significant. We'll have to see whether or not what the healthcare systems do with this result. But indeed, the data indicate that we can reduce cardiovascular events, even in patients that are ideally treated with statins and other drugs, to LDL cholesterol values of 90 milligrams per deciliter or less. Now, the only relevant side effect was local injection site reaction. And the other things that are listed here were of secondary importance. So this drug, aside from local injection site reactions, was very well tolerated, but I underscore the number needed to treat is 49, and we'll have to decide what happens here. But I think that PCSK9 as a target to lower LDL cholesterol is here to stay, and this is the first prospective randomized hard endpoint study to my knowledge. Now we'll have a look at the disclosure statements, and the authors seem to be heavily funded by industry. That's only the first page of disclosures, and you can look at the steering committee members and fees for giving talks and publication, whatever have you. It's all listed here. So the authors probably have some axe to grind, not trying to be critical here, but since these things are published, I thought we probably ought to have a look at them. The next topic in the New England Journal concerns patient with triple negative breast cancer. These women have breast cancer, but the cancers don't express the estrogen receptor, they don't express the progesterone receptor, and they don't express HER2, which means that the therapeutic options in terms of treating these patients with chemotherapy are relatively limited. And one possibility that's been discussed in the past is the inhibition of poly-ADP ribose polymerase. That's not the topic for today, but aside from PARP inhibitors, the options for these women with triple negative breast cancer are relatively limited. Now, what's been used in the past and relatively recently are checkpoint inhibitors, notably an antibody against PD-ligand 1, which had a favorable effect when compared to docetaxel, where docetaxel was the agent that was used as the control agent, comparing the effects of a checkpoint inhibitor to docetaxel in women with triple negative breast cancer. And this shows the principle where the antibody binds to PD-ligand so that PD-1 cannot bind to PD-1 ligand, which means that T cells, if this junction is impaired, should be more aggressive in terms of destroying tumor cells, and that's the hope. Now, in this study, in women with triple negative advanced breast cancer, means they already had metastases to liver, bone, etc. This is a comparison of PD-L1 antibody compared to a new formulation of paclitaxel that is a nanoparticle albumin-bound preparation that may enhance the anti-cancer activity, particularly in patients that receive antibody to PD-ligand 1. So in this intention to treat population, patients with triple negative breast cancer got the antibody plus paclitaxel as a nanoparticle preparation, and that was compared to patients that got the nanoparticle preparation alone and not the antibody to PD-L1. So here are the patients, 451 in each group, and then the patients were also subdivided into patients that express the ligand PD-L1. It would make sense that if we have an antibody to PD-L1, it should only benefit women that express the ligand. Although in earlier studies where we just looked at PD-1 inhibition, it didn't seem to matter whether the tumors expressed the ligand or not, which was always confused me a bit. But what we see here is indeed progression-free survival, perhaps not dramatic, but it's statistically significant over a 2-year period. The patients that got the antibody plus paclitaxel as a nanoparticle preparation did better than the patients that got the nanoparticle preparation alone. Not a great difference. If we subdivide this into patients that actually express the ligand, then this difference is improved, and overall survival is also improved as shown here. If we look at various subgroups in terms of metastases and where the metastases are, age of the patients, and these sorts of things, didn't seem to make much difference. And in terms of objective response as assessed by the investigators, comprised about half the patients that received the antibody. And if we look at adverse events, these seem to be relatively acceptable, so that we observe a benefit of antibody against PD-L1 plus paclitaxel as a nanoparticle preparation compared to paclitaxel alone. And PD-L1 expression seems to make a difference, and women that express PD-L1 benefit from this treatment, and women that don't express from this, the ligand, certainly don't benefit as much. So the tumors should be assessed prior to treatment to see whether or not they express the ligand. Next paper in the New England Journal, I guess, is a no-brainer. It's also a lead article in Spiegel Online. Früh eingeschulte Kinder bekommen häufiger ADHS-Diagnose. ADHS is attention deficit hyperactivity syndrome, and these are naughty or poorly behaved children that now run under a diagnosis code. And in this particular study, children that begin kindergarten at age 5 were compared to children that begin kindergarten at age 6. Now, in many states in the United States, if the child is born in August, then in September it's 5, and it can go to kindergarten. But if the child is born in September, then in September it's not yet 5, and it can't go to kindergarten. So what was done in this study is that there was a comparison of children that were almost 5 with children that were a year older when they began kindergarten. And if we look at reviews of attention deficit hyperactivity syndrome, as discussed here in German, the condition is more common in boys than it is in girls. In very young children, since all children are misbehaved between the ages of 3 and 6, the diagnosis probably isn't established. But once the children are in school, the incidence of this condition is reportedly much more common in boys than girls. Now, methylphenidate seems to help these children compared to placebo, as shown here. But that's not the point in this study. What was done here is that epidemiologists compared the attention deficit hyperactivity disorder in terms of month of school enrollment. And we have to do with 5-year-olds here. These are not first graders in the United States. These are children beginning kindergarten, and they were followed through time. So compared here are children born in August compared to children born in September. And the children that are born in September would lag 1 year behind the children that are born in August. That's what was done here. And what we see is then they compared the birth dates of all the children, and there's a blip here, and attention deficit syndrome is more common in children that are born in August compared to children that are born in September, indicating that younger children are more prone to develop this diagnosis. I would think perhaps because they're less mature than the children that are a year older. But I'm not a pediatrician and I'm not a psychologist. And here we see a comparison of states that don't care how old the children are. And here there's no difference that can be discerned, but states in the United States that have the September 1 cutoff, we see this difference comparing August to September. And again, as the literature indicates, it's a boy's problem instead of a girl's problem. The girls have a little blip here, but the boys are statistically significant more common in terms of carrying this diagnosis. So in conclusion, The findings are consistent with the hypothesis that the context of behaviors within a grade or school class influences the likelihood of a diagnosis of ADHD. I guess I'm not surprised. So I suppose that these little children that make the criteria for having attention deficit hyperactivity disease probably are all treated with methylphenidate. So I wanted to give you a little history about that drug. Methylphenidate was discovered in 1944 at Ciba-Geigy. And at that time, it was acceptable that investigators tried the stuff themselves before they had fed it to mice and rats. And Leandro found that his tennis game was much improved if he took methylphenidate. So it says here. And at any rate, because he was so impressed with the effects of methylphenidate improving his tennis game, he named the drug after his wife, whose first name was Rita. And for that reason, this drug is now known under the trade name of Ritalin. So if you wanted to know that, tell everyone you learned it here. The fourth paper in the New England Journal concerns the diagnosis of rare genetic diseases or patients with undiagnosed diseases that cannot be figured out. There are outpatient clinics for this condition also in Germany, and these clinics are connected by a network. There was some hope that I might be involved in this, but the university apparently has decided otherwise. But this is a report from the United States concerning the network with these unidentified diseases that no clinicians can figure out. What this network does, it presents the patients to a committee at the National Institutes of Health that run a metabolomics core and a central biorepository that does massive sequencing and exome sequencing to try to figure out these patients. And this paper concerns a report of 1,519 patients that clinicians couldn't figure out that were referred to this central undiagnosed disease network repository. And these experts selected 40% of these patients for further evaluation. And these patients that were accepted for evaluation had frequently already undergone exome sequencing and other diagnostic possibilities, but these patients were then sequenced further and studied by other techniques, presumably also metabolomics and this sort of thing. And the authors proudly announced that they defined 31 new syndromes. But if we consider that result in terms of they evaluated 601 patients and only identified 31 new diseases, perhaps then these results look a little less impressive. But at any rate, here's what they did. Some patients were figured out by clinical review by these world's experts, and other diagnoses were established by other means than genome-wide diagnostic assays, exome sequencing, or total genome sequencing, and all of these various things are listed here. And where these patients came from, most of these patients were white, probably because they have better access to health care in the United States than black subjects or Asian subjects or Hispanics or Indians, for that matter, who were less commonly represented. As a matter of fact, the poor Indians didn't get sequenced hardly at all. And the native Hawaiian or Pacific Islanders didn't do very well either. Then the disease categories, neurologic, musculoskeletal, these are commonly difficult to figure out. Immunological disorders, gastrointestinal, rheumatological, joint complaints, cardiac, etc. are listed here. And here are some things that were found, some new genes that had not yet been associated with a disease, to my knowledge. I'm afraid I don't recognize any of these, but you can read about them in further detail if you're interested in this, and you can look at these diagnoses yourselves. The patients that received these diagnoses generally could not be offered cures, but at least that they were given some hope in terms of what they had, and the results of these studies had some influence on their care. Now, the network that discovered these various things obviously also applied model systems to try to see if they could corroborate the diagnoses that they had established. And one of the model systems is the fruit fly. And here are some fly larvae that are shown as examples. I would imagine zebrafish would be another possibility to work up some of these syndromes. How much does all this cost? Well, it's not cheap. It's about $20,000 per subject that's evaluated, and the amount of money that was fried in this endeavor was well spent in my view, but this does cost something. So these networks are important in order to identify new diseases, but also to help these poor patients with these commonly catastrophic problems so that they at least have some idea what is wrong, or at least can be satisfied with the fact that no stone was left unturned. The review in the New England Journal concerned me a lot because it involves iron metabolism. And iron metabolism is terribly important for all of us. First of all, iron deficiency is the commonest disease worldwide, but iron overload is also fairly common, and we need to know something about it. Now, there are about 5 grams of iron in the average adult, and half of this iron is inside hemoglobin and is circulated around for obvious reasons. The other half of the iron is deposited in cells as ferritin, or is in transferrin, or is in myoglobin, or is contained in iron-containing enzymes. Now, our abilities to excrete iron are fairly limited. Most of iron is excreted when we turn over our gastrointestinal epithelium that we do at regular intervals. Now, menstruating women also lose about 30 milligrams of iron per month through menstruation, and that's variable concern in terms of how much menses that they make. And patients that lose iron because of gastrointestinal blood loss or because of hookworms or strongyloides are also at risk of developing iron deficiency. And iron is absorbed through divalent ion transporters, and how all this works has been worked out in wonderful detail. And the fact that there are transferrin receptors and that these receptors can be mutated, and that 5 genes that have been discovered that cause hemochromatosis, all of this has been worked out and is very exciting. And the role of hepcidin and controlling these processes is now also worked out, and I reviewed some of this material here. But patients with iron overload, either from hemochromatosis, adverse exposure to iron, or because people that get massive transfusions, they can't excrete their iron, and they get iron overload syndromes involving deposits of iron in liver, heart, testes, ovaries, adrenal glands, other tissues that can lead to a whole variety of diseases, including bronze diabetes, or arthropathies, or cutaneous manifestations, or liver cirrhosis and liver cancer, heart failure, impotence, and problems of this nature. And we can stain for iron if biopsies are made, or iron overload can be diagnosed by magnetic resonance imaging, and the radiologists are greatly helped if you tell them that you think the patient has iron overload, then they're more likely to make the diagnosis of iron overload, in my experience. Now, to deal with iron overload, we have several drugs, and one of them is deferoxamine. And deferoxamine has been around for as long as I've been a physician, and it's given to patients that have iron overload. But there are also other possibilities, including deferriprone, which is shown here, and the newest member that can chelate iron called deferrasirox. And these drugs are available for treatment with patients that have iron overload, and they have unique characteristics, including their pharmacokinetics, as shown here, and in terms of whether or not you can give them orally, whether or not they have to be infused over time. Deferoxamine is fairly tedious because it has to be infused for days, consecutive days, for long hours, and that's difficult for patients to tolerate. And deferoprone is rapidly absorbed, and whether or not the drugs result in increased urinary excretion of iron, which deferoxamine leads to increased urinary and fecal excretion of iron. Deferoxamine leads to increased fecal excretion of iron because the iron that's excreted is excreted over the bile, and deferoprone relies on urinary excretion of iron. Now, all this has to be known because if patients don't have any renal function, then there's no point in giving them deferoprone. So these things have to be known. The half-lives need to be learned. The molecular weights of these compounds are relevant, and how they're administered has to be known, because patients with this problem are relatively common, perhaps not in Berlin, but in patients with thalassemia major in the entire Middle Eastern region around the Mediterranean Sea, or patients that have emigrated to Europe or North America, or patients with sickle-cell anemia. These patients are commonly treated with infusions of packed red cells, and they're at risk of the patients with thalassemia major all develop iron overload. Now, there's a controversy here that this review in the New England Journal doesn't touch upon, and this controversy was initiated by Nancy Olivieri, who's an expert in this area. She's a pediatrician in Canada, and she claimed that deferoprone, although it decreases hepatic iron in patients with thalassemia major, might make hepatic fibrosis worse instead of better. And this resulted in the Nancy Olivieri controversy. She's known as a whistleblower, and she published a paper in 1998 that's not cited in this review in the New England Journal, indicating that deferoprone led to progressive hepatic fibrosis. Now, the company making this drug was rather annoyed and subjected her to substantial harassment, including sending her threatening anonymous letters. And this resulted in a huge controversy that has since died down over the last 15 years. But I would think that this review is Nancy is probably going to have some comments on this review, because in this review, this possibility that deferoprone could perhaps make hepatic fibrosis worse isn't mentioned, and her 1998 paper is not cited. Now, what's also possible is giving these drugs in combination, and deferoprone can be given combined with deferoxamine, and these drugs can interact so that one chelator can transfer its iron product to the other, which is then excreted, and then the chelator is available to act again. And we also have to consider some of these deferoprone can cross the blood-brain barrier, whereas deferoxamine cannot, and that might play some bearing on additional toxicities of iron overload. So this is all discussed in this review that claims that MRI measurements of iron in heart and liver are improved by these strategies, which I think that they probably are. But the controversy with Nancy Olivieri is not discussed. And I was interested to learn that some of the letters that Nancy received were analyzed in terms of their DNA content, and indeed people that worked for this drug company that were harassing her were found to be responsible for these letters. Wonderful story, all about whistleblowing. You can read it on your own. But at any rate, starting iron chelation therapy in patients with thalassemia major, probably surely in childhood, how it should be monitored, the use of these drugs in patients with homozygous for sickle-cell anemia or other anemias that are transfusion dependent. Also the possibility of using these iron chelators in patients with hemochromatosis is discussed here. And so the review is worth reading. Here's a picture out of the New England Journal. This is also a no-brainer. This is nail stippling, and these kinds of nails are pathognomonic in patients that have psoriasis. So if you see these kinds of fingernails, you need to look at the patient's skin. Sometimes psoriasis is hidden, but you should be able to find it because these nails are pathognomonic. Now the patient this week in the New England Journal is this patient. It's a 23-year-old right-handed woman that shows up with visual loss of the right eye. The left eye is in order, is okay. She also develops dizziness. She has, or vertigo, as we would call it in English. She has the feeling that the room is spinning, which usually indicates peripheral labyrinthian disorders. And she denies some other symptoms. Probably with clinical fundoscopy, without dilating the patient's pupils, these changes would not be appreciated. But with these wide field photographs of the fundus, here's the optic nerve head, looks okay, no papilledema, no sign of papillitis. These blood vessels look okay, but some of these areas are not normal, where all this white material is. And these changes suggest some sort of a vascular cutoff. Now, vascular lesions that result in visual loss, one might think of embolic phenomenon or something like that, but this patient has a constellation of findings, including vertigo. So the next step is fluorescein angiography, which is easy to perform, and also I can't read these, but experts can, and where the arrows are, there are supposed to be vascular changes suggesting some sort of a cutoff. I can't really appreciate these, but experts are able to do so. Now the discussant mentions what all this constellation of findings could represent, and disorders of the optic nerve head in young women are common and would suggest the possibility of multiple sclerosis involving the eye, which can occur and which is not uncommon, should show papillitis, but generally doesn't present like this. Disorders of the retina, which this is, and this is an example of branch retinal artery occlusion, which is abbreviated BRAO. Embolic disease, that this woman could perhaps have endocarditis. Cholesterol emboli would be less common. Infectious diseases of the retina, toxoplasmosis would come to mind here, or autoimmune conditions. Now this patient was tested for ankylosing, which doesn't commonly involve the eye to my knowledge, but this is an example of Suzak's syndrome, unknown to me. Behçet's syndrome should show mucocutaneous lesions that this patient didn't have. So what is Suzak's syndrome? So more imaging is done, and in terms of fluid attenuated inversion recovery imaging, abbreviated FLAIR, there are multiple lesions in the subcortical white matter, but she also has gray matter involvement and leptomeningeal enhancement, these things are not that typical in patients with multiple sclerosis, but would fit with Suzak's syndrome. So this is a local vasculitis that involves the central nervous system, and the discussant indicates that perhaps anti-endothelial antibodies are involved here. In my department, we've had some contact with those, although I'm not aware of having observed any examples of Suzak's syndrome. So this patient is treated with glucocorticoids and anti-B cell strategies, rituximab and things of this nature, and shows evidence of some improvement. Now we move to Lancet, and we're confronted with the STAMPEDE study. Stampedes are herd animals that go out of control, and we see an example as might have occurred in West Texas in the last 2 centuries ago, where this cowboy is trying to catch these longhorns on stampede. So in German, Wildwegrennen. So in the STAMPEDE study, all these poor men with prostate cancer and beginning early metastases were randomized to radiotherapy or not. Exactly why this is called the STAMPEDE study, I don't know. Perhaps some of the patients tried to stampede out of the study. But at any rate, it involves men with prostate cancer, and their performance level is still pretty good, and the severity of their disease was confined to patients with T1 to T3. There are a few patients with T4 disease here, and they received anti-androgen treatment and perhaps other chemotherapies for prostate cancer and were operated on locally, and then they received radiotherapy or no radiotherapy. The differences here in overall survival are not apparent, but in terms of failure-free survival, that means a progression of disease, there is some benefit to treatment, but it's less than profound. And if we look at this, it looks like patients that have a low burden of disease, in other words, they're pretty healthy and have few metastases, and their disease is confined to the prostate gland largely, they do better than patients that have advanced disease, as we might have guessed. And that's shown in the figure here. So overall survival, low metastatic burden is a little bit better in the patients that also got radiotherapy. In the ones with high metastatic burden, no difference. And so low metastatic burden might benefit from receiving radiotherapy, whereas the patients with high metastatic burden are then just confronted with the secondary effects of radiation therapy, which are not trivial. So, added value. At least it's a randomized controlled trial of radiotherapy, and those trials are few, and so we welcome the results of the STAMPEDE study. Next, we look at filgotinib, which is a selective Janus kinase inhibitor, and Janus kinases signal cytokine receptors, receptor tyrosine kinases that bind to cytokines. Erythropoietin is a prototype example of a cytokine, but there are many others. And many cytokines are involved, particularly in rheumatic diseases. And one example is psoriasis. And in this first study, patients that are already receiving all sorts of other treatments for psoriasis are randomized to filgotinib or placebo to see if selective Janus kinase inhibitor might make them better. And you're familiar now with the scores, the PASI score, and other tools that are used to assess the burden of psoriasis. And in psoriasis, we can look at the extent of surface involvement of the patient's skin, and look at their fingernails is a good idea too. And it looks like filgotinib beats placebo. And all these, whether there's a 20% improvement or even a 70% improvement of skin involved, which occurred in some patients, and a 50% improvement looks like Janus kinase inhibition makes these patients better. And we can look at other scores that show the same result. And I've forgotten what enthesitis is. I'm afraid you'll have to look that up on your own, but it got better. So the proportion of patients who had at least one treatment with this compound, intention to treat, was they did better. severe infections seemed not to be the case. Nasopharyngitis and headache occurred as side effects. So it looks that patients with severe psoriasis can benefit from this treatment. Now, if this is good for psoriasis, it also might be good for ankylosing spondylitis, and that hypothesis was tested in the next trial, where 58 patients with ankylosing spondylitis already receiving all sorts of other treatments were compared to patients receiving these treatments that got placebo. These are HLA-B27 positive diseases, for the most part, as shown here. And filgotinib made patients with ankylosing spondylitis better. And various scales, if there's a 20% improvement or a 50% improvement, there appeared to be improvement. And if the patients didn't have active disease, it didn't matter. So patients that had trivial disease didn't get better, but everyone else that had active disease, ankylosing spondylitis is a very nasty disease, and I think that patients that have this refractory disease will welcome this additional treatment. And this cumulative probability, we can see that the red dots seem to move more than the blue dots, indicate that the patients got better. Importantly, there were no malignancies, and severe infections were not prominent, and so adverse serious events were not common. So this treatment seems to help. Something else that's coming up is the use of artificial intelligence in medicine. Don't want to disturb any of my radiology friends, but one might think that if we teach a computer to evaluate 5,000 CTs that are normal, perhaps it'll find the ones that are not normal. And that was done in this study. And this study concerns brain CTs. And these CTs were put through computers that were able to evaluate normal CTs and learn about variants in normal CTs, and then were subjected to CTs that were not normal to see if they were as good as radiologists. The radiologists were given the benefit of the doubt and were declared the gold standard. So mark that down. Now the CTs had intracranial hemorrhage and intraparenchymal damage and interventricular problems and subdurals and epidurals, and all sorts of diagnoses are shown here. And the computers were pretty darn good, with a sensitivity of 98% and a specificity of 98%, if we assume that the radiologists were always right and they were given the benefit of the doubt. So here are the things, the diagnoses that were involved here, and these are the things that we would want a computer to find in a head CT: subarachnoid bleeding, epidural hemorrhages, subdural bleedings, interventricular bleedings, midline shifts, fractures, mass effects. I would hope so. And if we look at these rock curves, the computers are the smooth lines, and the red lines are the radiologists, and the computers are moving right up there. I'd be curious if we called the computers the gold standard and the radiologists the testers, and then see if the radiologists do as good as the computers. So the radiologists are going to have to confront this possibility that their skills may be the first that succumb to other modalities, including artificial intelligence. Here's a lady that has a lump at her neck. Is this scrofula? I don't know, but the clinicians involved here evaluated this lesion in this lady that had been on vacation in southeastern Turkey. And this ulcerating lesion is not scrofula. This is a syphilitic chancre. I'll let you read the details on your own. Now, the summary in the Lancet concerns gathering momentum and of liver disease in the UK. Maybe this is a reason for Brexit. Importing all of this alcohol from continental Europe might be contributing to liver disease. And it looks like the mortality in England and Wales and Scotland, the Scots are a little better at this than the rest of the UK inhabitants, probably because of Scotch whiskey. The Irish here are not evaluated. Of course, they've been independent for some time. Now, even beer affordability is plotted here. So it looks like things are getting worse, comparing projections for 2028 compared to 1980. And if we look at the price of a lot of this evaluation involves the cost of alcohol. And so there are some ideas about raising taxes here might make things better. And if we look at regulatory marketing and all these things that I don't understand, you can look at this if you're interested in this public health problem. And if we compare, this is alcohol also contributes to obesity. And people that drink a lot of alcohol are fatter than the people that don't. So if we compare London to West Midlands or to Scotland, the Scots are holding their own. Maybe that's why they're interested in independence. And if we can look at a funnel plot, didn't quite understand this, but this has to do with in-hospital mortality from non-elective liver admissions. So I'm not quite sure if things are getting worse or better here. You may have to interpret this on your own. But here's a breakdown of men versus women. And as we can see here, the men are always worse than the women in terms of hepatocellular carcinoma, etc. So the key messages, according to the authors, is 31% of men and 61% of women have alcohol-related obesity prevalence. And the authors recommend expert countering of drinks and food industry lobbying activities. Amen to that. So I looked in JMA to see what the Americans think about this and what we can do in order to diagnose this problem. And this review in JMA has to do with non-alcoholic fatty liver disease, where the authors claim that alcohol is not involved. So presumably these are all born-again Christian vegetarians that are nevertheless obese, and it's claimed that 25% of the adult population globally is afflicted by non-alcoholic fatty liver disease. And the other 75%, alcohol seems to play a role. So what do we do with this problem? Well, I think the first thing is we need to separate non-alcoholic liver disease from alcohol-related problems, hepatitis C, Wilson's disease, and other conditions. What can help us here, and I'm quite interested in this, is the fibrosis-4 calculator, whether or not the liver problem is clinically relevant. So in this thing that you can look at in the internet, you can type in the patient's age, his enzyme levels, AST or ALT, and his platelet count. And with that, you can determine whether or not it's worthwhile to consider this possibility further. And if you want to consider it further, you can do an ultrasound examination with elastography, and that's recommended, which would save a lot of these patients' liver biopsies, which would otherwise be performed. So then we can look at, should we have population-wide screening for non-alcoholic fatty liver disease? And the authors decide, well, maybe so, but probably not. But if with these simple lab tests, we might be able to at least decide who's worthwhile in assessing further with elastography, and what these things look like as shown in these pictures. And if we can determine the diagnosis with non-invasive techniques, maybe we can subject patients to less biopsies to see if they have these fat globules or perhaps early bridging as shown here. We'll stop with this report. This is a 60-year-old professional smoker. 300 pack years for 40 years. 300 packs a year for 40 years. He shows up with this fat lip. And this is not from a boxing match, because when we look at the biopsy, this is non-small cell lung cancer. So please stop smoking. That's it for this week. And if you want to hear the same business in German, hang around for 5 minutes and we'll discuss these issues further. Thank you very much for your attention.
Thank you.